It's a minute past 4, and those who know me know that I'm following from Germany and that I sometimes just can't help but really start on time. So it's a great, great pleasure for me to open up this meeting, to say hello and welcome to everyone. I'm opening this meeting with a sad eye because, as you all know, this is some sort of closing meeting to the Scope project. However, I'm also closing the session with a very proud eye because I'm extremely happy and extremely proud about what Scope has reached for EATG, as EATG, the European AIDS Treatment Group, is running this program for quite some time, and for all the people that were and are still involved with this project, so that I am hopefully and a little bit confident that this is not the last time that we all get together. You may be aware that SCOPE is something that we like very much at EATG. It's an acronym for amplifying, oh, wonderful, the slides match, amplifying community voices for prevention. Strategic Community HIV Prevention Empowerment is what it stands for. And I'm not quite sure whether Chiara knew when she set up this meeting that it would be a very warm day all over Europe and that we all would love to have a scoop of ice cream. That's at least what I would love to have and to share with you, a wonderful scoop of ice cream, to take a look back on what Scope has been doing and what carries on from what we have done at Scope. It's my pleasure not only to open this meeting, but also to give a huge thank you to all the wonderful people involved. When we are talking about communities, it sometimes keeps quite abstract. But with you, and I can't count all the wonderful faces I'm seeing here and those that I'm missing, you are giving those communities a face, a personality, and a very individual approach that enables EATG to really address those communities that we need for prevention and for empowerment. So now I have taken my 4 minutes, and before I pass on, I would really like you to make use of the chat, put in your questions. Don't be shy about commenting anything that you hear. We have an hour, and I'm quite confident that we'll take all your comments, all your ideas and questions, either we will answer them in this session, or we will take them to be answered afterwards. And now I'm very, very happy to pass on to Maria Plotko. Thank you, Maria. And I will shut up now for the rest of the meeting, and I will listen very carefully to what we all have to hear. Thank you so much.
Thank you. First, I think I would like to say that it was a pleasure to work with you and very interesting for me personally to learn about other countries, the ones that I don't usually work in, and to learn what is happening there with HIV services. I will start sharing the presentation now. You can see it, right? Okay. But I can't switch the slides. Okay, good. So first, a bit about the checklist based on which this report was made. So I was hired by EATG as a consultant to work on the HIV combination prevention checklist that was developed in the previous Hope project. And at that point, there was a pilot. And based on the feedback that the organizations who went through it provided, and with the help of Community Advisory Board, we changed the checklist quite a bit, I would say. Previous version of it had a score and was divided, all the services were divided by communities. And as I don't know, Kara, maybe you can put a link for the checklist if it's already available. If what you would see now, we removed the division by community and made it by the services, because as we all know, people usually don't have a clear community which they represent, and we have like they have intersectional vulnerabilities, and we saw that it would make more sense to do it like this. There are no scores as it's a self-assessment, and mainly it's for organizations to understand where they stand and what is the situation in the country. We tried to connect all the indicators. I'm not even sure that it's correct to call it indicators, but all the questions that are in the checklist with the global AIDS strategy and the WHO guidelines. So all the services that are listed there are one way or another mentioned in those documents, which is good in terms of future advocacy, that when the organizations see the gaps in the available services, they can refer to these documents and highlight that this is what needs to be funded or needs to be introduced in the country. In this assessment, 8 countries participated. It was Armenia, Croatia, Ireland, Italy, Slovenia, Spain, Sweden, and Turkey. And I saw among the participants almost all of the countries are present, maybe not all, but most of them. And as I mentioned, we divided the checklist in 6 parts. It's first is the legal context, then it's sexual and reproductive health and rights, HIV services, social support services, key population specific services, and then questions about service quality. And the report that, as far as I know, is not yet published, but soon will be published when you will see all the documents, is based on the checklist that was filled in by all the organizations, and also the narrative report based on this checklist. So to briefly go through the key findings, in terms of legal and policy environment, I would say that 2 countries in those 8 kind of stand out, as Armenia and Turkey is more restrictive. But still, the criminalization of sex work or drug use or sex relationship still in one way or another are happening in other countries as well. In terms of sexual and reproductive rights, the core services, main services are formally available. But as we would see, and the people would comment as well, the real accessibility is very different, and by communities, but also in terms of geographical location. HIV service for HIV services, antiretroviral treatment is free everywhere, but the accessibility is still different, and the other services as PrEP and PEP are very uneven, and in Turkey and Armenia, the uptake is very low, and as well as we'll talk about it in more detail, it's very medicalized and hospitals. Support and social services, I would say it's the biggest gap in all the services as we're speaking about HIV. They are available in general, but they're not tailored to any key population groups. And NGOs that usually try to fill this gap, they lack funding and resources to properly address those issues. Key population services, specifically, the biggest gaps are for services for trans community and for people who use drugs, and for migrant communities as well. Highest barriers are, as I mentioned at first, in Armenia and Turkey due to criminalization. And in terms of quality and community role, that community-led organizations, everybody knows here, are the ones that improve quality of every existing service. But at the same time, they are the rarely recognized or funded properly. Recognized in terms of being part of the response. Um, in more detail, legal and policy context, Sweden and Spain both have universal health systems, and they, as well as Slovenia and Italy and Ireland and Croatia as well, they have anti-discrimination laws and have good services for key populations, but the real accessibility and like the context is looks like very enabling for this for the services to be really good, but in practice there's still a lot of issues with access. In more restrictive countries as Armenia and Turkey are very criminalized. There is a lot of stigma, and which really affects the access to services. And stigma, I would say, even in the more enabling environments legally, stigma is still a very big issue and still prevents people from accessing services without the help of NGOs. Sexual and reproductive health services. So what works is a cord contraception, I mean like condom distribution and STI treatment, which is available everywhere, but mainly it is not anonymous and hospital centered. The good points from countries is like in Spain, there is good there is a possibility for adolescents, also underage people, to use the services confidentially. And the main gaps are the same access to reproductive services for same-sex couples. In several countries, for example, in Italy, anonymous STI testing and access to these services without proper documentation and, for the migrant communities. We also got a comment from Turkey that even public condom distribution near ceased in the recent years. And as with all the services, NGO role is here to provide this low threshold testing. But again, it's not really funded or available. But it happens in some of the countries, and NGOs also help to navigate what kind of services actually exist and where and how to get them. HIV specific services. So all countries have free HIV treatment. 5 out of 8 provides treatment no matter the legal status in the country. In Spain, Spain has a very good statistics in terms of HIV and very good PrEP coverage. Sweden also have universal access, but and Abimbola will comment on that, the real situation for migrant community is very different. In Ireland, also free HIV treatment regardless of the status. They have home testing kits, which I think is a very good practice. I know that some other countries have it as well, but I'm not sure anyone in this from the ones in this list have it as well. In Slovenia, there are 2 HIV clinics, and in Croatia, there's only 1 HIV clinic. So if the service is available, but in order to start the treatment, most of the people need to travel to this 1 or 2 centers. which is also a big barrier, especially for speaking about key population groups, and not only. And in Armenia and Turkey, PrEP and PEP are outside of reimbursement, so which means it's not free. Second. As I said in the first slide, support and social services is the biggest gap. And as we know from practice, and as we see now in all international guidelines as well, enabling environment and social support services are really key to access the treatment, to stay in treatment, and to not get anything else on top of it, and then to improve people's life. But at the same time, these services do not exist and they're not tailored for key populations group. They are not tailored to, they're tailored to an ideal client who basically doesn't need the help of the services really much. But if the person really needs the services, usually there are a lot of barriers in terms of access. And NGOs, of course, fill this gap and try to stretch their mandates and provide everything that is possible, including food, pocket money, job search, community spaces, and support groups and psychological services, you name it, anything. But these services are rarely funded in terms of like separate funding for these services, and the capacity of NGOs in terms of people as well is very limited. And geographical availability, I guess, is the main thing for everything that we talk about here, because usually all the services exist in capitals or big cities, and rural communities will face challenges accessing it in every country on the list and maybe everywhere. In terms of key population-specific services, there are trans and gender diverse people in Italy and Spain, very fragmented healthcare, lengthy, medicalized. I saw there is a person from Ireland, and then in the among the participants, and in Ireland, the waiting list is estimated for 10 years in order to access the services. In Armenia, there is no legal gender recognition, and there's a lot of problems accessing the services, and lack of trans competent providers are documented in all countries. In terms of people who use drugs, I would say Slovenia and Spain and Ireland have the most diverse services available, and Armenia and Turkey have the least number of services available. In terms of sex work, the situation is also not very good. There's in Spain and Sweden, there's criminalization of third parties. And in Italy, there's police harassment, and then public decency rules that push sex workers outside of the city. And everywhere, I think sex workers face police harassment and try to avoid the health services. Migrants and displaced people, there are formal access, which on paper should be possible, but then the fear of services, and then the problems with language, and even not only understanding each other, but also properly understanding the service itself is a big barrier. And communities, the NGOs and community groups are trying to fill in these gaps and provide safe spaces and provide peer support and tailored information and do outreach and accompany people to all the services. But in general, there are, wait a second, I'm just trying not to repeat myself and try to say something. There is a lack of targeted training in terms of general services. I'm not speaking about NGOs, but in general, social support services, they don't have a proper training in terms of serving the key population groups. And this is why the stigma still is very high in those groups and over time. So I will just move to conclusions and recommendations, and if you have any questions, you can answer. I can answer them. So based on the data that we gathered, there are 5 main recommendations: is to reform laws and policies to decriminalize sex work and drug use everywhere and adopt human rights centered harm reduction and other services and anti-discrimination legislation that would help people access those services, turn formal availability into real access, and make community-led services part of the system. That I said that despite the fact that community-led organizations are the ones addressing those issues and actually helping people reach care and stay in there, are rarely recognized as part of the solution and properly funded and listened to in terms of designing the services or distributing the government funding. Build social protection into HIV care, include all the mental health, psychological, legal, and other services, and establish the coordinated navigation system between the services, and improve the quality through rights-based care, which means mandate regular training on human rights, stigma, gender diversity, harm reduction, and cultural competence for all health and social service providers, and include community organizations in those training, and basically make them lead and design those trainings. Thank you. I think that would be it. And then I'm open for questions. I don't know if it's better to pass the word to Abimbola now, and or we will stop with this presentation first. I don't know, Kara, what would you say?
Hi. Abimbola, if you want, maybe you can also present unless there are some rapid questions from everyone. Otherwise, Abimbola, would you like to present and then we can take some questions at the end?
Yeah, okay, bye everybody.
And thanks, Maria, for presenting.
Okay, let me see. I can share, right? I hope I have the right.
Yes, you should be able to share.
Yes. Hold it now. Is it? Can you see it now?
Yeah.
Okay. Lovely afternoon, everyone. Nice seeing our faces. It's a pleasure to be representing Noazak Mosaic. I also want to quickly say that the scope actually gave us a very good template to actually review what we do. So that's very important to us, because sometimes you are so busy trying to give service. However, you do not have time to review or to put what you do in a structure that can be a template for others to learn from. So we really appreciate that from EATG and the Scope project. So we just want to talk about the things we were able to learn and how it affected our work. particularly the community-led HIV prevention access in the south of Sweden. We work in the south of Sweden. We are a national organization. We have about 6 other sister agencies, organizations throughout Sweden, but we are working in the south of Sweden. Yes, particularly how we use the checklist as a tool. We saw it as a structural reflection of what we do. You know, like I said in the introduction, that we do a lot of things, and then you are head deep in things until when maybe a third party comes and then help you to structure. So we saw it as a structural framework that actually put all that we do in such a way that even for advocacy, it became so easy for us whenever we engage with the politicians and all that. We can able to tell them specifically, you know, using those grouped key indicators like it was presented earlier. So we also use it to engage with our staffs. Also, we have a model which we learned from the core, which are the peer workers. We're able to use it, you know, in getting them engaged in a meaningful way. And of course, the access in terms of the services, the linkage, the referral system, and also highlighting the cultural competence that we could get out from all those key indicators. So it's such a very beautiful one for us. Also moving very quickly because I think I have 5 minutes. It helps us to map the key services, even though we know that they were there, but going by those key indicator, key structure, we're able to put them in place and it became easier for us. And of course, we're able to know that in Sweden, publicly, the HIV services are funded adequately. However, the gap still remains. The ones we could identify quickly, barrier particularly for migrant population, because we prioritize key population, and then when we put it on another level of vulnerability, being migrants will also, you know, increase those vulnerabilities. So we were able to map that correctly to see those gaps. I saw somebody asking in the question about how did we map the gap and other. For us, we were able to see those gaps, particularly for the people we work with. For example, if you don't have a personal number like a social security number, with you being a migrant, it may be difficult for you to access care in some instances. So we recognize that, and then we help those people to be able to link them up with care. So, of course, the referral pathway most at times are not culturally sensitive. And then from snowballing, people will tell themselves that you do not go to that VOS center or the hospital because they will not attend to you well and all that. From their lived experiences, they can now say, oh, don't go there, don't go there. But we come into that space to be able to link them up properly. So those are the things that we've been able to learn and be able to see clearly. And of course, in terms of reflection, or I would say recommendation, it's very good if other countries can adopt this to be able to see a pathway that is simplified, particularly for their key population. Because in Noah's Ark Mosaic, we prioritize migrant group. And of course, on that other level, we have other key populations who are represented also under that migrant group. And then it becomes so difficult for them because of where they are coming from, the language barrier and all that. So these are the things that we learned from. And of course, strengthening NGO public healthcare collaboration is very important thing that we were able to learn, that if we could scale this up amongst ourselves, amongst the NGO that plays within the space in Sweden, this can actually help us, because most of the time, some of the funding that we have for projects are just too short. We can't go ahead with that. And of course, if they can also use this tool, it will really help them to map out what they are doing, what are the services, what they can scale up, and then coming together, we think is something that we have learned, reflecting on this tool and improving cultural competence also, which can fight stigma and continuing involvement within the community, be able to design a program that can help the community we serve. So it's a very good one to summarize. I wish the policymakers can see this when the report is out, for them to adopt, for them to be able to see the critical need from the community perspective, not just designing things and then pushing it to the community to be implemented. It's better it comes from us, and then they can adopt it. We can sit at the table to be able to give the community we serve a good service. So thank you so much for your time, and thanks to EATG and the consultant that had worked on this project. Thank you.
Thank you, Abimbola. If you have any, I feel that we're rushing. There are many countries and a lot of information, but we have 30 minutes left, I guess, in the call. So if you have any questions, please ask, but be brief, or we will try to answer it in the chat box. I don't know, Kara, which would be better at this point, and then move to the second part of this meeting.
Maybe if there's really one quick question, or you can put it in the chat and we can answer also via email after.
I think
this
Axel
call.
wrote a question in the chat, just so you know.
Axel, do you want to ask your question to Maria directly, or?
Yes, if you like. Well, I'm not at all involved really with prevention, but more in care about persons with HIV. But I'm involved with the development of the HIV plan in Belgium, which is now an HIV, STI, hepatitis B and C plan, and that will be in different countries. And I think what I hear was very interesting about the indicators, because this is lacking mostly in our previous plan. And if you want to make a plan in real life, you need to measure. And therefore, I think it's very useful to get, certainly for me, more info about how you did achieve or how you came to these key indicators. And do you have a kind of case where you use it in one specific country and how you use it? Because that could be on policy level as well very useful to push for.
Thank you for the question, but I think that's why I said that indicators maybe is not the correct word for me to use, because what we did actually map the available services. I think what you mean by indicators is some kind of a goal or the success rate, or like how do you measure that the services are effective or accessible and everything. This is not the goal of this checklist. And Amanita?
I would love to add just a quick link here, and maybe Chiara and the rest of the advisory board from the Go project can support me in this, and maybe correct me if I'm wrong. But many of the indicators that have been included, many many of the different points on the checklist and many of the different points on this forum that we have come directly from the Global AIDS strategy from 2021 to 2026, which basically provides technical guidance for the United Nations, and based on the work that we do at UNAIDS, on what are those biomedical and psychosocial needs that the different key populations have, and therefore what are the services that different let's just say community-led organizations, but also other type of organizations are providing to keep a priority population. So, I mean, maybe this can complement a little bit your answer, Maria. because at the end, what we're basically doing here with the concept of HIV communication prevention, it's to try to create a way of monitoring whether the programs are in fact aligned with what the global literacy strategy is suggesting and what the political declaration was suggesting, which is also, when I get back to you, we will be talking a little bit about the current political context and how all of the work that we're doing at Scope, it's also related with the global HIV response. I'm going to leave it there. Maria, just take back from.
Yes, thank you. That's absolutely that we try to, all the services that I mentioned are also mentioned in international guidelines. We did not create it. It is already there in all the official documentation, and the countries sign it, and we just try to see what is available. But I know that when we go to the country level, when you talk about plan and indicators, they have a bit of a different vision of what it means. That's why I said maybe it's not exactly what we're looking for. Chiara, maybe now back to you.
Thank you, and thanks, Abimbra, also for presenting. I think we can move on to the next part of the webinar, and then if there's any other questions, happy to answer via email in the chat or anything. And I will hand over to Amanita and Marco, who will present our speakers, participants of the project, and yeah, thank you.
Thank you so much, Chiara, and hello, good afternoon to everyone here. I am so happy to see so many friendly faces. When we were having a conversation with the team from EATG and the advisory group, I was telling them that in the program and that all the people that had been subscribing, like I felt like this is just basically a hangout with a group of friends, because I look at your faces and I've seen all of you. We've been hanging out with like pretty much all of you, and it's just so freaking nice. This is in fact a community space where we have figured out ways to just to create this really wonderful network of advocates, activists, researchers that are community members that we are like in fact having a huge impact on the HIV response regionally and globally. So I just wanted to start by saying that we have today in this second part of the final meeting of Scope. Let's just hope that is not completely final. Let's just put it to sleep for a little bit, hibernation during the summer, and then we come back maybe later in the winter next year. We'll see. But we have a couple of amazing people that we've been working with, people that had already a wonderful, strong voice, and we have just tried to use some of the funding and some of the networks that we have to facilitate a platform and support the work that you're already doing. So the next couple of minutes, I will be inviting 4, if I'm correct, right, Chiara? It's going to be 4. We're going to have Osla, Joanna, Teresa, and Leo coming to present to us, just really quickly in a 2-minute elevator pitch format, the work that you have been doing with the Scope program, with the Scope project for EATG, and then after that, we're just going to have a little bit of a conversation. I would like to follow up with putting into context the importance and the relevance that both like the Scope project is having in matters of the global HIV response, especially in such a critical point right now, given the fact that the high-level meeting is happening in less than a month, the political declaration 2026 to 2031, it's been negotiated, but also very importantly, that the United Nations Joint Program, UNAIDS, it's transitioning into a different model. And this is exactly the moment where we need to be very active and have complete clarity of what are the things that we're going to be advocating at regional and global level in order for us to have a proper HIV response that follows up for the next 5 years and that in fact puts communities in the lead. So with no further ado, Joanna, Teresa, Osla, Leo, I'm going to give the space here to you, and I'm just going to choose one of you. I'm going to go with Teresa first because, I don't know, you were first in my screen. Teresa, you have 2 minutes,
Hi.
my love. Here we go.
Can you hear me properly? Yeah, perfect. So my name is Teresa. I'm from Portugal. I'm a social worker. And I was involved in the Scope project first in the Berlin workshop, Community in Scope project. And then I went in a study trip to Metzneres. in Spain, which is a harm reduction space for women victims of violence and marginalization and who use drugs mostly. So for me, it was very interesting to in the bad sense, I guess, that support and social services are the biggest gaps, and particularly for the most marginalized communities. And that services are made for perfect people who do not need those services, and that's very true. And a very useful thing that Scope did for me was to move the conversation beyond individual behavior, and to systems, power, to access. And we cannot talk about HIV combination prevention when people have no stable housing, no access to health, no mental health. And it was amazing to be able to talk about it in community, in Berlin first, and because as a social worker, social determinants of health are something that's very relevant to my work. And I believe that the biomedical, behavioral, and structural factors are all equally important. And how important is community? How important are peer-led and bottom-up interventions to achieve this goal? So, if I had to describe this in one sentence, it would be that services have to adapt to people and not people to services, I guess. Thank you.
Oh, perfect, Teresa. Thank you so much. Can you hear me? Yes, I muted myself. Thank you a lot for that very clear, quick 2-minute elevator pitch. I love this format, and we're gonna have time to talk a little bit longer about this. Let's continue now with my dearest Osla. After that, we're gonna continue with my timer, and after that, we're gonna go with Joanna, and then we're gonna finish with Leo. Leo, okay? So, Osla, the floor is yours.
Hi everyone, my name is Ozla. I'm from Turkey. I'm currently based in Switzerland. I wanted to highlight a sentence Maria said while describing this access in Turkey. Turkey has least of everything. That is so true, except new diagnoses. In case you do not know, Turkey currently has one of the fastest increasing or growing HIV epidemics in Europe and also around the world, with around 60,000 people diagnosed in total since the first diagnosis in 85, and around 4 to 5,000 people getting diagnosed, new diagnoses every year. So we just started diagnosing people. That's kind of where we are. Access to treatment, medical treatment is relatively good. That means if you have a Turkish citizenship, you will most likely have access to medication. That is why you may see some papers reporting like over 90% access to treatment. But actually, if you're a migrant, if you're a refugee, it is very challenging, especially if you're a queer refugee. And PrEP looks available on paper, but accessing is almost impossible. And we have surprisingly increasing number of anonymous testing. That's where we are. So access to biomedical interventions to a certain extent, but our biggest issue is actually access to social care and information on HIV. And that's where we kind of got involved in the SCOPE project as well, because we used a translation grant to translate an HIV treatment guideline, so to say, produced by iBase, which was basically breaking down HIV treatment science with pictures to simplify it as much as possible. That's what we have done. I have worked with, so I'm part of a queer-led HIV initiative in Turkey, which is not registered. Because of our activities, we're afraid of registering because we know we will be closed down within a month, probably by the government. So instead, I now registered an organization in Switzerland. And as one of the first activities we've done, we used this translation grant. And we covered certain areas in the document. We covered HIV life cycle, HIV progression without art, understanding test results, and how treatment actually works biologically and scientifically. The document has ended up being a bit too scientific than we aimed, and the scope kept getting wider and wider because there were so many issues we could have covered it with. But overall, we are very happy that we were part of this project. And I just had a call with a team member of ours earlier in the morning. We posted our guideline, or HIV with pictures guideline, a couple of weeks ago, and it has already been seen by 15,000 people, which is a huge thing for us. That means not only we think there is a need, but it also has attention and gets clicks when we do activities such as these. If you have any questions, I'll answer them.
Absolutely fab, Osla. Thank you so much for that. We will definitely get back to you with some more questions. But first, we're going to continue with Joanna. Joanna, would you like to go next? You have 2 minutes.
Countdown. Hey, everyone. So I think one of the thoughts I want to express is that in drug user activism world against what's happening in HIV, that's why it's so good to work intersectionally. We get difficult to get access directly to those affected by the prohibitionist policies, money or small grants to do our work, peer-led, let's say. And in the times we are even getting in more difficult to get access to small funds, like any small grant project makes a huge difference for us. So I'm Joanna. I'm part of Euroinput, the European Network of People Who Use Drugs, but I'm also part of MANA's, a peer-led collective of women using drugs and doing sex work based in Portugal, Lisbon. We are supported by GAT, Treatment Action Group. It is part also of EATG. So with this, we could make out of our small grant for translation of resources. With Euroinput, we had done a few years ago an HCP best practices with the Gatin Morari in Lisbon and Prolar in Norway. And we could actually do not only do the translation of this resource, but also to do a focus group with the women participants of MANAS to discuss message to get more people in testing and follow up to treatment. So we did a flyer, we did a video also appealing for testing and treatment, not only in Portuguese, but also in Crioulo, a dialect from the African region. And so I think we increased the ways we can informally pass the message among peers to get more people tested and in treatment among ourselves, let's say, without the usual help of the NGO world, which is very helpful, but it's also very helpful that we can do it by our own ends. And that's it. And
I am
also,
so excited. So continue. Go
Leo
ahead.
has the I cannot share the screen, but Leo has like maybe the flyer. We can just check it in 30 seconds or so.
Def.
I don't know.
I
if we
mean,
can...
oh Jesus. I was actually just gonna let Leo speak now. So, thank you so much, Joanna. I am super excited to hear like all the amazing work that everyone has been doing. Leo, you are the last one of this four. The floor is yours, my dear.
Thank you very much, Amanita. And thanks everybody for having us here and having us part of the Scope project. So with Joanna, I work the European Network of People Who Use Drugs. As Joanna mentioned, we're the regional drug user network fighting for the health and human rights of people who use drugs in Europe. So yeah, for us, this project, I think, was kind of building on amplifying the voices of the community of people who use drugs, not only through just giving them a platform, but also from the very core of the involvement. So Input has several key thematic projects that we work from. Our peer-led harm reduction series is one of them. So as Joanna mentioned, one of those documents is the best practice around HCV testing, treatment, and care that we highlighted best practices from Portugal and Norway. So as part of this project for Scope, we built on those peer-led harm reduction series, and we took our peer-to-peer NSP, technical briefing, peer-to-peer naloxone, and the HCV testing, treatment, and care. And then we had three groups. So we had Manus in Portugal, we had Pollenpud in Poland, and we had Mantlagalette, Novelob, and Transitox in France. So it was a really good spread of geography and languages. And we had each of those groups used the grant in different ways to develop the resource as they wanted to. So Manus adapted it into a flyer and a video, which I can show later or I can link later to everyone. And then they also included, each country had case studies in the documents that they translated. So yeah, it allowed Input to, I suppose, develop further into this different, looking at different translations. Euro Input works in English. We're a very Anglo-centric network. This allowed us to kind of move beyond that in terms of information around HCV, HIV, testing, treatment, and care, and into different languages. Is really important for us. And yep, just brief about the three groups. So Pollen Pud had the three resources, and they used them and are going to continue to use them in Warsaw and Krakow. Pollen Pud is a drug user group led by women who use drugs. In France, we had Transit Talks in Paris, Mat La Galette in Mat La Jolie, and Nouvelle Aube in Marseille. So again, different kind of geographical spread. And those three groups are made up of people who use stimulants, people who smoke crack, trans people, migrant people who use drugs, people of color. So a really good spread of different intersectionalities with this project, which I think is really important. And yeah, I can share stuff now, or I can share it later in terms of the videos and the flyers that we made. But thanks very much. That's my pitch.
Thank you, Leo. That was fab. Okay, my entire life I have been ostracized and excluded or victim of violence, whether it is because I'm a migrant or a trans woman or a person who uses drugs or because I do sex work or you name it, right? Every single time that I think of all the violence and the loneliness that I've been exposed to, I remember spaces like this one. Because in spaces like this one, I literally feel like everyone here is doing something to make my life a little bit better. And for that, I love you madly. Every single project that has been created here by Euro Input, by AIDS Action Europe, by EATG, by EX, by you name it, like all the organizations that are present here are genuinely making as much effort as possible to create a real HIV response that addresses the needs of the community. So for that, again, thank you so much. Thank you, Maria, so much for that report. And I want to, like, before we continue to like the questions and I would like to just put a little bit things into context, because the report that Maria presented and the different programs that have been shared with us by Osla, Joanna, Teresa, and Leo are completely related to everything that is going on right now. So as we know, the high-level meeting on HIV/AIDS is happening this June, 22nd of June of 2026 in New York City, where the political declaration is going to be negotiated. We know that this political declaration on paper should be inspired by the Global AIDS Strategy 2026-2031. But the United Nations, it's been a little bit difficult about a couple of things, and the process is not as clean and as straightforward as we wish, which is the reason why having reports like this one and having programs like this one allows us to understand what are our red lines and why is it so important that we advocate for those red lines. We need to, and again, taking from that report that, oh my God, sorry, I am getting a phone call. Taking from the report that Maria was mentioning, the United Nations Joint Program on HIV/AIDS, the NGO delegation, we wrote the NGO report last year that was published in December, and it's labeled Community-Led Integrated Services, the Future of the HIV Response. If you have not read it, I really do encourage you to go ahead and read it, because it's basically like taking this, but like to the next step. Why? Because what we're suggesting is to take the concept that EATG has been promoting so strongly and beautifully, like HIV combination prevention, including testing, treatment, prevention, linkage to care, and then combine this with several other programs that are known to reduce HIV, like the risk for HIV acquisition among key and priority populations. That is comprehensive sexuality education, sexual and reproductive health and rights, which include abortion, and fertility services, includes harm reduction programs like all the ones that Leo just described. It includes trans-specific healthcare, including gender-affirming hormonal therapy and legal gender recognition for transgender people, comprehensive sexuality education for youth, so on and so forth. Let's put all of that together into one space, one model. Let's the community lead, and let's just leave the UN take care of the technical and administrative guidance. And that is what we're advocating right now, especially in a moment where where UNAIDS, it's being restructured and it's going to be transitioning into the overall UN system. What we need to be advocating for, therefore, it's very much down these lines. And I think that having a conversation in this space, like it's the last thing that I'm going to say in the topic, having a conversation in this space is very important, because we need to mobilize member states to advocate precisely for those things. So having said that, now I would really love to open the space for everyone here to ask questions to the different to like all the different people here included. Marco, why don't you start, and then
Yeah,
we take it from there.
thank you, Monita. And thank you, everyone. But more than a question, maybe I need help because I'm from Italy, from Brescia. We have a small HIV organization. And if during the testing events, we reach a lot of different population and it's really good. When it comes to peer group of people living with HIV, we we have only gay men and we have very difficult to spread our this group and to have a different population inside this group, and we don't know why. And so maybe because there are people from different community here, maybe you can help us to understand why there are only gay men in the people living with HIV group, because we try our best. Our communication is not MSM with the naked man. We don't like this, but it's really difficult for us to reach different kind of population. I don't know if makes sense my questions. And so
Who would like to take that on?
Sorry, the question was that it's difficult to reach different populations.
yes, different population, specifically for the group of people living with HIV, but also for in general. It's very difficult for us. We reach heterosexual people and we reach men people, gay men, but it's difficult. We don't reach out trans people. It's very difficult, and so I'm from the north. Brescia is between Milan and Verona, and so we are try our best. We have connection with our local pride. We do events together, but maybe it's just question of time. Maybe we are a young organization, so maybe in the future the staff will improve, I hope.
Okay, Marco, but then maybe Osla, you can go, and then Vera.
I'm going to be a bit cheeky and ask you a question back. What is the representation of the communities that you're trying to reach out to within the team that is trying to reach out to them? Because it has been my experience that usually if you have a community member, they can give you insights that I cannot give you, having not been there or lived there. So maybe that's something to reflect back on for your team and maybe go to the funders and actually say, we need people from these communities.
Yes, of course. We don't have any. We have different community, but not trans community, not people of UCR community in our team. And so I know that this is a problem. But in the next autumn, we will do a new volunteer course, training course, and I hope that will more different people join our volunteer team for sure. But for the moment, no. I know that this is a problem, and we are trying our best, of course. Thank you.
Thank you, Osla. Thank you, Marco. Vera, go ahead, and then Gus.
I just wanted to quickly bring the sex workers issue into this conversation. Of course, I know that many checkpoints have been built next to red light areas, but as sex work is changing and is moving online and it's more difficult to reach out sex workers, you have to make a double effort and keep doing like online reach out with some sort of system or strategy to build trust, and probably give them something in exchange. So keeping in mind their situation. And I just want to say as well that even if I'm a former program officer of the European Sex Workers' Rights Alliance, please do not leave them, do not forget them. They're still working, they've gone through a transition, but they're full on. So yes, just this is my humble contribution, and I hope it helps.
Thank you, Vera. Gus, go.
I mean, I don't belong to either of those populations, but I have a few ideas. I mean, I think I would go further. It's not just about representation; it's about power. It's about allowing people from those communities to actually run services. If you want to have the best example of a really good set of clinics that was started up for transsexual people, then you have to go to Thailand and Southeast Asia and look at the Tangerine clinics, which are a fantastic example of HIV services, which are not merely just represent trans people, but are actually run by trans people. And talk to them, ask them how they did it, because it started in Thailand and then it went to Vietnam. And yeah. In terms of sex workers, one of the best examples I've seen is actually in our very own London. And there is much more about how you reach people. This is a community of mainly East European migrant sex workers who have a special clinic at the London Hospital. And basically, the way that community was built up was by using the very media that they used to connect with clients, namely WhatsApp, simply just like starting a service on WhatsApp, which offered weekly checkups and things like that, and basically kind of becoming part of their circle of people they got in touch with. So there's various ideas, but it's not just about sort of having people, at meetings. It's about people actually being able to actually run or participate in meaningful services.
Thank you, guys. Okay, do we have any other questions or any other comments that we would like to add? Because we are running out of time, and I wanted to give some space for Vera to close the meeting. So if we don't have any further questions, I'm going to pass it on to you. And before that, I just want to say goodbye to everyone. I will see you all for sure very soon. And it's been really nice to work with you on this project.
Thank you, everyone. So it will be Chiara who will formally close this meeting, but I really wanted to first mention the incredible work that Chiara has been doing throughout all these months, holding the pot. It's been a very versatile project with lots of different activities, a lot of emotions and journeys. And yeah, thank you so much, Chiara. And last but not least,
We love you.
Yes, we love you. If I have to define somehow what Scope has meant to be, it's been a space where we've been all able to shine with our own light. But we didn't become a traffic light. We became a beautiful kaleidoscope where our lights intertwined, and we formed a beautiful rainbow. I really hope that we're gonna keep working together and that our lights will keep intertwining, because the future looks very dark, but we will not let ourselves and our lights to stop shining. So I will see you all around, and thank you, Chiara. The floor is yours.
Thank you, Vera, and thanks everyone. You're gonna make me blush. But thanks for being here, and thanks for being part of the project overall. Yeah, the event today is a closing meeting, but indeed we hope it's just to see you soon, as cliche as it will sound, and hope to see you back. And we'll keep working on this, keep pushing for these rights. And yeah, in the meantime, we'll still publish a few blogs. The research report will come out this week. So yeah, keep an eye out for that and keep being in our loop, and let's keep in touch. And yeah, thanks for being here. Have a lovely evening, and yeah, thanks everyone.
Thank you.
Bye.
Thanks, everybody.
Bye.
Bye.
Everybody.
Bye.
Bye.
Thank you.
Bye.
Bye bye.
Thank you. Thank you.